What?
As for your registration for the lecture, it's enough, or if you submit your data to this form, using this form, uh, you may see it in the chat or in the invitation for today's meeting. Do you see the link URL? Yes, you have it both in chat,
Yes, yes,
in
yes.
in your invitation for the lecture. So I'm lucky to meet you, those who are present in the lecture and those who will see it in the recording. I have started, and let me introduce myself. My name is Oleksiy Kalmykov. I'm professor of Kharkiv National Medical University, more exactly, the Department of Internal and Occupational Diseases. And I apologize for possible, maybe something what may happen, because now at the moment we have blackout, and I found one of places where possibly there will be connection, there will be internet, and there will be enough electricity supply to conduct our lecture. Even if I fail, anyway, I'll make a recording for you in this topic, and you anyway get appropriate information in our today's two topics. Um,
Doctor, thank you.
Today we have to discuss two diseases or two group of diseases, anemia and leukemia. The links to appropriate presentations are supplied, they are included in the invitation, just exactly in the text of invitation for today's lecture. And you are welcome to use these materials, as well as you are free to uh, connect me directly and ask your questions regarding these topics or any other related to internal medicine, or maybe wider spectrum of clinical problems, as well as the methodics of scientific research in medicine in general. Uh, One more thing, I also apologize for possible some additional sounds that might happen sometimes, because now I'm sitting in the reception room of the hotel, so they could be some sounds, some additional sounds. Good. Let's return to our topic, anemia. Oh, for instance, let me check if you have registered successfully. You haven't yet, right? Because I'll immediately see your registration here. So don't forget to register for the lecture, please. And let's continue with our today's topic, anemia. By definition, anemia may be described, for one hand, as a disease or even a group of diseases, for other as a syndrome, sign, manifestation of different diseases. As a disease, as a group of diseases, it might be described as a disease characterized by decrease of either hemoglobin concentration in blood and or the red blood cells count, erythrocytes quantity. As a clinical syndrome, it's a sum of changes in the organism, which are characterized by disturbance of the one of main functions of blood with transferring gases, and on laboratory level it is characterized by decrease in hemoglobin and red blood cells count, while at the level of the whole organism the main sign of anemia is hypoxemia and hypoxia. So hypoxemia is decrease of concentration of oxygen in blood, and hypoxia, decrease of oxygen in tissues, so oxygen supply. The typical complaints in case of anemic syndrome include general symptoms and more specific. In general, it's fatigue, decrease of workability, general weakness, sometimes even some syncopal conditions, loss of consciousness, especially while changing the position from lying to vertical. And there could be some cognitive disorders. So they are just general, not so specific. From side of cardiovascular system, these changes appear to be more constant, more typical, more characteristic. It's a feeling of dyspnea or breathlessness, is increase of heart rate, this feeling of palpitation. And if some cardiovascular diseases have been before development of this anemic syndrome, it's worsening of them. For example, if there was heart failure, if anemic syndrome appears, heart failure becomes more severe, more expressed. And same for coronary artery disease. If there were some kind of, for example, stenocardiogenic or in myocardial infarction or um, myocardial fibrosis and so on, or sclerosis, there is or diffuse changes of myocardium. They start to get manifested more severely, more expressed. On physical examination, the most constant symptom is paleness of skin and mucous membranes. US future dentists, stomatologists might detect unusual color of lips. They become more pallid or some whitish sometimes even. And same for the discoloration of tongue and mucous membrane of oral cavity. You may also detect change of color of sclera as well, some more whitish, right? Or maybe grayish sometimes. From side of cardiovascular system, objectively, we may detect tachycardia, maybe sometimes even systolic murmur on the apex. Here is the typical outlook of elder person with anemia. You may see this pallor, some paleness of skin, and mucous membrane, and lips, right? Here is the comparison of skin color on the hands from normal person from the right, and with anemic syndrome on the left. Here is the outlook of tongue. It becomes pallid, right? The laboratory test detects the decrease of hemoglobin. In an international unit, it's 12.5 grams per deciliter, or according to um, what other approach, it's 120 grams per liter. The classification of anemias have different approaches. has different approaches, and one of approaches is pathophysiological or pathogenic. We distinguish three types of anemia from this point of view. Uh, Anemia resulting from loss of blood. Second one, anemia as a result of hemolysis, so destruction of erythrocytes. And third type is when anemia develops as a result of disturbance of production of red blood cells or hemoglobin. Other approach to classification is by degree of severity. We say that the severity is mild if the decrease of hemoglobin is about up to 20, right, percent from initial level, moderate severity from 20 to 40 degrees, and severe if more than 40, not degrees, but percent, and severe if decrease happens in more than 40% from initial level. The deviation or variation of hemoglobin concentration in blood within 5% is normal. It's no problem. Third approach to classification is based on ability of blood system to regenerate. From this point of view, we distinguish normal regenerative, when reticulocytes count does not exceed 1.2%, hyporegenerative, when reticulocytes counts is less than 0.2% from all the amount of red blood cells, and hyperregenerative, when the reticulocytes count exceeds 1.2%. Let me remind that reticulocytes are the young, or we also name them immature forms of red blood cells, of erythrocytes. So therefore, if organism, if hematopoiesis becomes more intensified, bigger amounts of reticulocytes enter the bloodstream, and we detect them on laboratory investigation, laboratory test, and vice versa. If there are problems of regeneration, less amounts of reticulocytes are produced and enter the bloodstream. The fourth approach to classification of anemias is based on color index, right? Or main corpuscular hemoglobin concentration, maybe. We distinguish hypochromic, when MCHC, so mean corpuscular hemoglobin concentration, is less than 32 grams per deciliter. It is typical for iron deficient anemia. Then other variant is hyperchromic, when this mean corpuscular hemoglobin concentration exceeds 36 grams per deciliter, and it's typical for B12 folic deficient anemia. And normochromic, when mean corpuscle hemoglobin concentration is within these limits, from 32 to 36 grams per deciliter. This happens in the majority of different anemias. The fifth approach to classification of anemias is based on the size, on diameter of erythrocytes. We distinguish three variants: normocytic, the mean corpuscular volume is within 84 to 96. Microlytic, accordingly less than 84. It's typical for iron deficiency, hemolytic anemias. And macrolytic, lytic, which is typical for B12 folic deficiency. Let's continue with iron deficiency. The iron deficiency is also named sideropenia. Sideros in Greek means iron. Panic means decrease of something. Sideropenic syndrome includes a wide spectrum of symptoms connected with uh, the depletion, the decrease or blockage of function of iron, including dryness of skin. It's because of disturbance of production of sweat and the trophics of tissues conducted by blood and especially in terms of oxygen supply. Then fragility of hair, nails, and so on. There could be even deformations, and you might observe these changes from side of the face skin and especially lips and oral cavity as well, and so on. Just one moment. Probably I have some problems with. Mhm. Hello, are you here, dear students? Hello, are you there? Do you hear me? Mm, dear students, Ibrahim, are you here? There was some problem with connection, probably. I'm not sure if now it's okay. Hello? Mhm. Ibrahim, if you hear me, please say anything. Or, yes, I see. You wrote a yes, right? Thank you. I'll return to the lecture. So they could happen sometimes, something like that, because of these problems with. Good. So we have been discussing the problems related to iron deficiency from side of mucous membranes and skin. There could be changes on the lips, on the skin of paraoral skin, right? Region, area. Here is the one more example of these changes. And these changes appear from the whole body. Just one moment. Sure that I'm still online. One moment. Good. You may see such changes from the skin of shoulders and here from side of finger and on the side of from side of nails. Good. And one more deformation. Good. The other aspects of sideropenic syndrome may be related to gastrointestinal tract, such as decrease and distortion of appetite or dysphagia, constipations, or vice versa, diarrhea. This depends on the motor function of intestine. If it is increased, there is diarrhea. If decreased, the constipation. glossitis, so even inflammatory changes from side of oral cavity, esophagitis, and so on. Here are some illustrations, such as changes from side of tongue. One more. You may observe such a smoothening of the surface of tongue. And this develops because, and this happens from side of the whole mucous membrane, not only of tongue. And this is related to such a mechanism as hypoxemia and hypoxia, disturbance of trophics of tissues, and therefore um, decrease of quantity and shape of cells and tissues and so on. And you may observe this uh, the in dynamics with increasing of these changes and so on. Worsening. Cytopenic syndrome may also get reflected from side of higher function, cognitive functions of the person, such as predilections for some smells, so acetone or petrol or something like that. Then angular stomatitis, it's mostly related to skin and mucous membrane. And there could be inclination to eat chalk or toothpaste, or there could be or ashes of paint. So there are unusual such desires. Swallowing of normally with sensation of foreign body in the throat. So there could be some paresthesias as well. The causes of iron deficiency may be related to, in the majority of cases, it's related to blood loss, so hemorrhages, different locations. They could be physiological hemorrhages in women or some pathologic in case of injury or something like that. Iron deficiency is common, unfortunately, in vegetarians as well. So vegetarians should take care about these aspects. So they should supply themselves with iron and control its level in blood and in general. Then there could be one of causes prolonged achlorhydria. Achlorhydria is decrease of acidity of mm, stomach juice, right? And this is related to disturbance of the mucous membrane function and decrease of absorption of iron from intestine. There could be also extensive surgical removal of some parts of intestine or development of chronic inflammatory diseases in intestine. Both of them, both of these cases, causes are related to decrease of absorption of nutrients in general and iron among them, including. And there could be vice versa, increase of requirements in iron, such case as in case of quick growth of the organism in children during pregnancy and lactation, or in sportsmen which have extra loads, physical and mental, and so on. So this disbalance of uh, income and requirements of iron or in iron may lead to development of appropriate symptoms, as we have discussed with you. And especially symptoms are just manifestations. What is more important is development of appropriate changes in the organism. The laboratory studies in case of iron deficiency show the following changes. If it is chronic iron deficient anemia, there are mostly microcytic hypochromic changes of red blood cells. So there are small cells and with decreased mean corpuscular concentration of hemoglobin there. Then we may directly measure the concentration of iron and reveal its decrease if normally the serum iron varies from 13 to 27 micromole per liter in men and 11 to 25 micromole per liter in women, we may observe decrease. Then, vice versa, increase of iron binding capacity. The total iron binding capacity is from 45 to 81 micromole per liter, and decrease of serum ferritin. The normal range of ferritin varies from 30 to 300 nanograms per liter. The laboratory studies may also reveal decrease of sideroblasts in bone marrow. I must say that in the majority of cases, we do not need to perform bone marrow aspiration biopsy, right? But if we perform, we detect these changes. The medical care in case of iron deficiency anemia starts from correction of diet to increase the iron uptake and to maybe increase the quantity, the portion of dietary iron from ham or non-ham fractions. By ham iron or ham fraction of iron, we understand getting it from meat, from liver, and so on. Some mostly animal origin, and the rest maybe got from vegetables, from fruits, and so on. While the efficiency of absorption and in introduction, inclusion in the metabolism is much higher from ham iron than non-ham. And I remind you that this is one of cases when vegetarians may suffer from iron deficiency. If we do not succeed with the dietary approach, we may continue with using uh, pharmacological preparations. For example, ferrous sulfate up to 300 milligrams daily, or even parenteral injections of iron preparations in case if there is not enough ability of absorption from intestine, or if we do not succeed with the treatment, even using diet and peroral medicines, we continue with parenteral. The next type of anemia is related to deficiency of B12, with vitamin B12 and folic acid. We name this anemia, one of synonyms we use is megaloblastic. It corresponds to the size of red blood cells, increased size. Right? The fact is that cyanocobalamin or vitamin B12 and folic acid are widely used in different metabolic processes, including nervous system function and production of red blood cells, erythropoiesis, and for instance, in other enzymatic systems, it's widely used as well. And deficiency of vitamin B12 directly gets reflection from side of these systems and organs. Um, so this is the description of, I have described in brief the pathophysiology and the causes. Decrease of vitamin B12 might be nutritional. It's simply because there is lack of it in the food. They could be due to malabsorption, for example, decrease of acidity of in the stomach or inflammatory changes in intestine and so on. There could be decrease of production of intrinsic factor. By intrinsic factor, we understand mucopolysaccharide, which is needed to get bound with vitamin B12 and to successfully get absorbed. So, and normally this mucopolysaccharide saccharide is secreted, it's produced in the mucous membrane of stomach. But if there is hypoacidity, if there is hypoplastic conditions, the production of this substance gets decreased, and this results in malabsorption, so with disturbance of absorption of vitamin B12. There could be also severe abnormalities of terminal ileum due to resection or inflammation or tumors and so on. One other possible cause of vitamin B12 deficiency and folic acid deficiency is presence of parasites in the organism in general, and especially in intestine, because of they simply use this substance for their needs. And the use of some medications may also result in deficiency, such as cytostatics, anticonvulsants, oral contraceptives, non-steroid anti-inflammatory drugs, diabetic, and so on. The clinical features of megaloblastic, or we also name it vitamin B12 folic deficient anemia, are anemic syndrome. We already know what it consists of. Jaundice and changes from side of central nervous system and gastrointestinal tract. The so-called symptom of Hunter's glossitis is manifested by sore tongue and it becomes swelling of tongue and enlargement of it, and uh, sometimes they could be even trophic disorders of it. From side of nervous system, these patients might represent symptoms of polyneuritis or polyneuropathy in form of numbness, paresthesia, or general weakness, and ataxia, disturbance of the posture and walking. They could be also non-specifically, of course, sphincter disturbances or disorders, changes of reflexes, and so on. Now, of course, mental disorders as well, not specifically. On the laboratory tests, one of the typical, I must say, even almost specific manifestations of these conditions, or maybe condition, I mean, vitamin B12 folic deficient anemia is microcytic anemia. These big cells appear in the smear and Based on this, laboratorian may point out that this might be such a disease. The red blood cells, in this case, as an exception, uh, is so they are these red blood cells are fulfilled with hemoglobin, and the color index or mean corpuscular hemoglobin level might be even increased. This is an exception. In all other cases of anemia, it remains normal or decreased, but in this case, increasing. And there could be also hypersegmentation of neutrophils. This happens by different reasons, of course, or because of different causes, but the main is activization of them and uh, the change of morphological condition. While this kind of anemia might be accompanied by decrease of production of other lineages of hemopoiesis. And vitamin B12 folic deficient anemia may be accompanied by leukopenia and thrombocytopenia. They might be not so severe, but anyway, they could be present. Here is the outlook of nucleated red blood cells. It's like an anomaly in this kind of disease. One of additional tests we may perform and ensure that we have really disturbance of hemopoiesis. Just a moment. Check. Yeah, connection is okay. Is direct measurements of cobalamin. Normally, it varies from 3 to 900 picograms per milliliter. If we perform bone marrow biopsy, we may observe a decreased myeloid to erythroid ratio. Here is the outlook of the smear. And a part of changes from side of blood system, they could be also increase of unconjugated bilirubin and lactic acid dehydrogenase in plasma as a result of systemic increase of rupture, increase of metabolization of red blood cells, and increase of bilirubin as a result of this. And on abdominal X-ray, there could be signs of inflammatory changes from side of gastrointestinal tract organs. The medical care in case of approved condition related to deficiency of vitamin B12 and folic acid is treatment with the appropriate substances, such as cyanocobalamin in the dosage of 1000 micrograms is used parenterally for 2 weeks and then gradually evaluation of increase of parameters of hemoglobin and red blood cells. And all the rest of approaches to treatment of anemias are maybe also applied, but injections of cobalamin are most specific. The next type of anemias are related to hemolysis, rupture of red blood cells. And there is a great variety of different mechanisms and causes of hemolysis. It could be intracorpuscular, extracorpuscular, hereditary or acquired. And the main laboratory clinical signs of hemolysis include anemic syndrome, reticulocytosis, it's hyperproliferative type of anemia, jaundice because of increase of bilirubin, then hepatosplenomegaly because this big amount of ruptured red blood cells require involvement of these two organs into metabolization. Then augmentation of urobilinogen content in urine as a result of its bilirubin increase in blood. And same for stercobilinogen content in feces. And the level of unconjugated bilirubin elevates significantly in blood and even in urine sometimes. And low or absent levels of serum haptoglobin is typical for this condition, with possible rising of level of serum iron because again of rupturing of red blood cells and entering of iron into bloodstream. The lifespan of red blood cells in this case is typically shortened. And if we perform the biopsy of bone marrow, we may detect erythroid hyperplasia there. The clinical manifestations of non-clinical in this clinical and laboratory, right, um, include anemia, spherocytosis. The shape of red blood cells becomes or it turns more closely to sphere, and splenomegaly increase the size of liver and spleen, and there could be also thrombosis of veins and positive direct Coombs test. Here is the description of the approach to treatment. We perform the stabilization of cellular membrane, and if we succeed, or we vice versa, if we do not succeed, there could be even a need in splenectomy because of these intensive autoimmune reactions, uh, and further continuous supports of these patients. So there could be different causes and mechanism, cold reactive antibodies, and so on. And let's continue with other type of anemia named hypo and aplastic. This type of anemia develops in case if there are problems with production of red blood cells or their uh, inclusions, right? So let me see. It's time to make a break, but if you don't mind, I will not make a break and we'll simply finish slightly early. Okay, Ibrahim? Maybe some other. So, thank you. Just a moment. Thank you. I'll return to the presentation. A plastic. In this case, we may observe the selective aplasia, decrease of production of red blood cells only, and nothing more, or there could be more total depletion, like disturbance of thrombocytopoiesis and myelopoiesis and so on. and lymphopoiesis even sometimes. The clinical manifestations in case of hypoplastic and aplastic anemia include anemic syndrome, hemorrhages because of lack of thrombocytes, syndrome of infections because of lack of leukocytes, and the laboratory studies we reveal the decrease in platelets, red blood cells, granulocytes, monocytes, and even reticulocytopenia. And this condition is indication to perform the bone marrow aspiration, the biopsy of bone marrow. And there we detect all these components. Here is the outlook of bone marrow smear. From left, we have normal condition. From right, aplastic anemia, or hypoplastic at least. The treatment in this case includes bone marrow transplantation, anti-lymphocyte globulin, anti-thymocyte globulin. Well, it depends on the cause of this condition, because it may even correspond to development of leukemia. And this is one of our today's next topics. So let's move to leukemia. Okay. Leukemia. In order to understand better the just a moment, let me check if I'm live. I'm live, probably. Good. Uh, in order to better understand what exactly happens in different types of leukemia, we'll have a small introduction into hematopoiesis and then continue. So hematopoiesis is the process of production and differentiation, maturation also, of blood cells, with their further entering in circulation and conduction of their function. The bone marrow is mostly in adults, is also mostly located in bones. That's one it is named bone marrow. Here is the distribution of the predominant location of hematopoietic cells in different organs depending on age, before birth and after birth. We should also remind the components of bone marrow or components of circulating blood, cellular representatives, cellular populations. We formally distinguish several lineages of hematopoietic cells and final functional cells as well. Erythropoietic. Oh, basically, let me even show you, just one moment. Okay, we'll continue slightly later with this. And the functions of bone marrow include hematopoietic, production of blood cells, immunity, because of production of immune cells, formation of bones, because the presence of and development of bone marrow inside the bones significantly impacts the growth of bones as well. Then bone marrow also takes part in all types of metabolism and serves as a blood depot. The classes of hematopoietic cells are the following. The first class is multipotent hematopoietic stem cell. It is also named hemocytoblast. This cell might reproduce itself, or this set of cells, of course, they're not only one. These cells have an ability to reproduce themselves or differentiate or mature, transform into other cells. Any hematopoietic cell of both myelopoietic and lymphopoietic. And they form the second class of hematopoietic cells, the pre precursor of myeloid direction, myeloid lineage, and lymphoid lineage. And they are named appropriately myeloid stem cell and lymphoid stem cell. And then on the third class of hematopoietic cells, we have precursors of the final functioning cells, such as megakaryoblast. Later will become platelets or thrombocytes. Proerythroblast will later differentiate into red blood cell, into erythrocyte. Myeloblasts will differentiate into basophils, neutrophils, and eosinophiles, and monoblast into monocytes. Same in lymphoid lineage. Lymphoblast will later differentiate into natural killer cell or lymphocytes, T or B. So let's focus on first three classes. The mutation or disturbances in these three classes result in the development of acute type of leukemia. And these cells of three classes have general name of non-differentiated blasts. The parameters of and functionality of hematopoietic cells and in general blood cells is needed to understand the peculiarity of developments of clinical manifestations and even laboratory changes in case of leukemia. For example, the life duration typically significantly different in separate types of blood cells. In red blood cells, it about 120 days. In platelets, about 10 days. In granulocytes, like neutrophils, eosinophils, basophils, it may vary from, no, it's about 2 weeks in general. And in lymphocytes, it may be from 2 weeks up to half a year, for example, approximately. Some of them, memory cells, may remain for years even. Therefore, if some problems in production of these cells appear or develops, uh, we may observe this clinically and on laboratory level after appropriate quantity of days or weeks or months or such a period. So the leukemia, by definition, is malignant oncological pathology in hematopoietic cells with primary localization in bone marrow, and only then dissemination to all the organisms. So again, leukemia is oncological disease, tumor simply, with primary location in bone marrow. A part of leukemia, there could be also development of hematosarcoma, while hematosarcoma is a tumor which develops from hematopoietic cells but doesn't affect bone marrow. And all the variety of tumors or oncological pathology related to blood system So these diseases are named hemoblastosis. Sometimes they name it cancer of the white blood cells, but it's not correct, because cancer, by definition, is a tumor which develops from epithelioid cells, while hemoblastosis develop from mesenchymoid cells. So it's different. We should not name it cancer. And now let's continue with acute leukemia. So acute leukemia is a variant of leukemias resulting from mutation of hematopoietic cells of first three classes. If you remember, there are, maybe I'll show you now. And chronic leukemia is a result of mutation of next two classes. The epidemiology of all types of leukemia is about 13 cases per 100,000 of population per year. It's more often in males, and acute types of leukemia more often in children and young persons, while myeloid leukemia more often in elder people. And there is no so significant geographical variation. On this slide, I try to represent the proportion of different types of leukemias. Acute lymphocytic lymphoblast leukemia is about 11% and so on. And as you can see, the most often is acute myeloid leukemia. The etiology of leukemias correspond to two aspects: internal, endogenic and exogenic. Endogenic is genetic anomalies, and exogenic correspond to either ionizing radiation influence or chemical substances influence or viral infections. Let's discuss them more in details. Ionizing radiation influence. The dosages exceeding 1 joule per kilogram, or it's equal to 100 rad, increase the morbidity in leukemia as well, such as cases of population of Hiroshima and Nagasaki, then development of leukemia after radiation therapy related to other reasons, not leukemic, and occupational hazards corresponding to those people who work under the influence of ionizing radiation. The chemical substances which form a high risk of development of leukemia include aromatic hydrocarbons such as benzol, xylol, toluol. They result in the myelotoxic effects, and typically this leads to development of chronic myeloid leukemia. Then smoking, pesticides use, chemotherapeutic medications, and so on. And viral infections may also result in mutation, and we have even a special retroviral infection of human T-cell leukemia and other. And finally, genetic predisposition. The genetic or hereditary predisposition cases include, for example, Philadelphia chromosome, it's translocation from 22nd to 9th chromosome, and it's a feature, it's one of laboratory signs of chronic myeloid leukemia. Then in case of Down disease, it's trisomy by 21st chromosome, rather often result in acute myeloid leukemia. Klinefelter syndrome is trisomy by X chromosome. Uh, Viscott-Eldridge syndrome is X-linked, and other aneuploidies, translocations lead to decrease of stability of genome and predisposition to mutations and therefore development of tumors in general and including leukemia. Here is the illustration of this translocation plan from 22nd to 9th chromosome. And here is the outlook of this blood smear in fluorescent light. Just one moment, I have to change my head. I mean, ear plug, because it has been discharged. Good. Okay. The pathogenesis of leukemia is still uncertain, while we know a great amount of data about it already. And one of most maybe close to